Okay. So again, good afternoon, everyone, and thank you for joining us today. My name is Katrina Hernandez, and I'm a behavioral health consultant with OPEN, the Overdose Prevention Engagement Network. Welcome to today's webinar, Pediatric Postoperative Pain Management. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of your presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME continuing education credits for today's webinar. We'll have a slide up with the information about obtaining those credits during the Q&A portion of the webinar, and we will also email the continuing education credit information after the webinar today. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain. We offer expert-led education and training sessions. Most of our webinars offer continuing education credits, and for prescribers, all of our credits also qualify for the DEA required SUD training. We provide MOUD training for clinicians, and our next training is coming up on March 5th. And this year we are incentivizing primary care providers with $250 to complete one of our MOUD trainings. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable education materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. We provide safe medication storage and disposal options, and we also provide overdose rescue support, including naloxone vending machines and distribution boxes, as well as naloxone administration trainings. So today we want to welcome Dr. Perrone. Erin Perrone, MD, is a faculty member in the section of pediatric surgery. She received her medical degree from Wayne State University and her general surgery training at the Detroit Medical Center, Wayne State University Department of Surgery. She completed pediatric surgery fellowship at Loma Linda University Children's Hospital. She is board certified in pediatric and general surgery. Dr. Perrone is part of the Fetal Diagnosis and Treatment Center team and is specialized in prenatal consultation with her evaluation for potential fetal intervention. Her practice includes all areas of general pediatric surgery with specific interest in congenital malformations and neonatal surgical diseases. So thank you, Dr. Perrone, for being here, and I will turn it over to you.
So thanks, everyone, for joining with your lunch hour today. I know that our time is very valuable, so I appreciate the time that you are giving us. Hopefully we'll all learn together today about some of the important things between a physician and a surgeon involvement, specifically in the opioid overdose epidemic. I'm hoping to share with you best practices in using non-opioids, specifically acetaminophen and ibuprofen for first-line management of pain, and also learn about some strategies to reduce any risk associated with opioid prescribing in the pediatric patient population. This is just an outline for the day. You can obviously all see it, and we'll go through each of these things carefully. I'm sure you all know about the opioid crisis and that in the year of 2023, over 100,000 people in the US died of a drug overdose death. This rate has been increasing. It certainly, we saw a rise during the COVID epidemic. Most recently, thankfully, it started to go down, but we don't know if that trend will continue or not. We are certainly hopeful, but it is clearly something we cannot ignore. We also know that this is not just affecting our adults. It's certainly affecting our youth and specifically our teenagers. And it affects our boys more than it does our girls. But certainly it is something that we have to continue to lean in and decide and figure out how to avoid this. Why opioids? I think they're fairly easy for our teenagers to get. We know that about every 10 minutes, a child visits the ED for medication poisoning. But when we start looking at it, about 3 in 5 teens will say that pain medication is very easy to get, usually just from their parents' medicine cabinet or someone else that they know. I have a colleague who told me his son had knee surgery once and said within about an hour of him getting home from the hospital, his friends were calling him. So the kids are talking about this and trying to get the medications when they can. And then we know that at least 12.5 million people over the age of 12 misused opioids in the last year. And then the question is, of course, as a surgeon, I would only give pain medications around the operation time. But what we know is that, and we have studied that new persistent opioid use in adolescents is a true thing. So we used to think we would just give it to them for the time they're going to the OR, and that they would use what they need. But with study and with time, we found that at least 1 in 33, so around 3% of kids were getting another opioid prescription at least a month later, which is concerning given that a lot of the diseases I look at are, 1 in 2,000, 1 in 5,000, something like that. We spend a lot of time looking into how to best treat those, but this is affecting more patients than even that. We see overdoses increasing. There's been a 109% increase in monthly overdose death of adolescents from 2019 to 2021, and 30% increase in intentional overdose ED visits, especially in our young girls. And this is Michigan related data, so it is in our backyard. So what can we do? We can improve our prescribing patterns. I started training in the mid 2000s, and it was very common for us to give pain medication with multiple prescriptions or refills, because we didn't want to have the patient be in pain. Pain was the 5th vital sign, and everybody wanted to make sure that we minimize the pain as much as possible, which of course we want to minimize pain, but I think it certainly swung to putting a lot of these opioids out in the world that patients may not have needed. And of course, the persistent opioid prescribing after surgery is a concern because we've introduced the opioid medication to them. So we want to have a better understanding of the risks, and overall, we want to lead to more cautious prescribing practices amongst all of us, and of course, learn all of the updated guidelines especially for our pediatric patients. So in pediatric medicine, we are thankfully at a point where I think most of us are decreasing the number of opioids we prescribe. I can say a handful of years ago, I personally had a huge shift. I used to send patients home with at least a handful of narcotics or at least a prescription in case they were to need it. And that is virtually down to 0. And by just concentrating on some of these other ways. So we have seen a decrease, which is great, but we still see that it's out there. So we want to try to educate everybody and come together on how to address it if this happens. So the decrease in opioid prescribing appears mostly to have started with adolescents. I think most of us realize that those were probably the patient population that had the highest risk of abuse with these medications. So that's where we focused at first, but certainly that has been a trickle-down effect. And like I said, I have rarely ordered non or opioid pain medication for a patient post-op in the past handful of years. Of course, concerns remain. We have to be always thinking of mental health and the potential for any sort of biased care delivery. We know that providers are more likely to recommend opioids to Black patients. We also know that we treat our female patients differently than our male, and we describe pain in a different way for them. So we always want to check our biases while we're doing this. We also know that the COVID pandemic has significantly increased the mental stress and mental kind of mental health effects upon all of our youth. And we're concerned about what that means, especially if these kids who are already undergoing all of this stress in their life are being exposed to opioids. So we've certainly done some work with Open and other groups to provide some recommendations and to ensure that we are looking at this with a close view. We're going to talk through some of the emerging trends and potential patterns and how inconsistencies do remain. But hopefully at the end of this, you will see that there are very effective non-opioid pain management options for children that I hope to add to your armamentarium if it's not already there. Of course, we have to do this together. One surgeon or one practitioner ordering or not ordering opioids doesn't make a difference, but if all of us work together, then we can make some substantial change by following evidence-based standards, providing the non-opioid based strategies, and creating a culture of opioid safety and consistent messaging amongst all of us. Of course, that doesn't go without educating our patients and their families, and then encouraging safe storage and disposal when we do need to use opioid prescriptions. So we certainly don't want to swing the pendulum too far, and we don't want people in unnecessary pain. This is a link, so if you use the QR code, you can view online all of our pain management resources. There's lots of toolkits that you can use for your teams or for your patients. They're very full of colorful pictures and whatnot, very well done. And there's things you can just print on your own for your own edification. You can also apply to our group. I think in the chat, you will have a link if you want us to send you some of the free printed copies, which can then be used in your office for your patients and your teams. So we're just going to go through a little bit of best practices. This is for surgeons. Obviously, this is what I do, but perioperatively, we really want to make sure we have consistent messaging. We want our families to understand what pain management is and what the medications are, any risks. We want to teach them up front about storage and disposal. We want to be sure that all of our verbal and written instructions are actually consistent, right? If I tell them one thing, but my nurse goes in after and tells them something different, then patients will certainly get pretty confused. So we want to make sure our teams are all on the same page. And then we want to coordinate and any transitions between the different care providers who are taking care of the patient and make sure that there's shared expectations and that patients aren't just doctor shopping between any of us. So this really starts for me in the pre-op counseling period, as early as possible when we are choosing to do a surgery for a patient. I really talk about what their pain management is going to be. I let them know that the expectation of having zero pain is just not realistic, and that means we're probably over-treating the pain. We all know the Likert scale of 0 to 10 for pain. I certainly don't want patients sitting in a pain scale of 8 or above, but if they're sitting at 4 or 5 most of the time, and maybe even a little less, that's probably okay. But if they're all the way to 0, then they are in sleeping all day, then they are certainly being overprescribed. I certainly don't provide opioid prescriptions routinely, and it's something that we try to get under control prior, and I make sure people know that. And I talk about some of the risks of why that is. Intraoperatively, I talk a lot with our anesthesia team about how that they're managing the patient's pain during the operation and immediately post-op. If there is any way to do any local or regional blocks, we ask them to do those at the time. I think that really helps. And then I typically have them administer non-opioid medications intravenously, so Toradol or Tylenol, prior to the patient even waking up in the post-op unit, as long as it's safe. And then immediately post-op, we have a lot of non-pharmacological techniques. Any distraction or child life, having the parent at the bedside when the patient is waking up from the post-op unit. I think all of those things are really good. And then, of course, having our PACU nurses well-versed in all of this too. And then when it's appropriate, we start enteral non-opioid medications, as long as it's, again, safe to do so. If we are going to give opioids in the recovery area, which sometimes we have to, we try to do them orally versus IV to be able to have them a little bit longer lasting and have the patients be able to be discharged without them. And of course, if we can't, and sometimes we do operations that we know that the patient's going to have more pain than traditional, we heavily utilize our pain service and have them help us to mitigate the pain experience for those patients. Lastly, the discharge considerations. You certainly want to do non-opioid therapies as your primary method. I'm a huge fan of doing Tylenol and Motrin and to maximize those before using any sort of opioids. And then we also want to do all of the other things: distraction, heat or ice, physical therapy. Sometimes we use these lidocaine patches that will minimize the pain on the incision, and any other thing that we can do to avoid the narcotics. This is a nice pictorial that we have just for the dosing. Of course, a lot of our patients are smaller and young, so we do milligram per kilogram or weight-based dosing. But you can go up to the maximum doses for an adult, which we've included on here. So we obviously don't want to overdose anybody if they are larger, especially in the obese population. You don't want to give more than you would give an adult. But you can take them individually and alternate them. We really recommend for more of the moderate or severe pain to take them together. And then every 6 hours, and for at least 1 or 2 days after surgery, I have my patients take them around the clock, even if they don't think that they're going to be in pain, and then I have them start spacing it out after. And we really talk about the simultaneous use because it seems to be that has pretty similar or improved pain control when it's compared to medications where they include the opioid in it. So the Tylenol and opioid combination ones, seems like the giving Motrin and Tylenol together in the big studies have shown that they're pretty equivalent, and that there's a longer lasting pain management. And by taking it around the clock, that allows people to not get behind on their pain medicine and have it sort of be a steady state for at least the first 24 to 48 hours. Initially, I used to tell all of my patients to have them alternate, which made sense in my head to have them go every other. So there was always one of the medicines working more or another. I think that's really hard for our caregivers, because that means they're going to be taking a medication every 3 hours. So now I recommend that they take them together to make it a little bit easier. Hopefully that they will adhere to it better, reduce the likelihood of missing any doses. Also allows for a little more sleep if they can have a full 6 hours in between. Of course, if there's any issue with that, I suggest that they try to break them up a little bit. So what do we do? Because sometimes we do need to do opioids, and that can be that for whatever host of reason, we want to make sure that we use shared decision-making with our patients, and we want to make sure that we tailor that to our patients and make sure that there's an evidence-based approach as to why we're doing it without compromising their recovery. We have a lot of recommendations within Michigan. We have been able to decrease the prescription size by about 76%. without any change in any patient-reported pain or satisfaction. So we're not asking people to go to zero by any means, but we are hoping that we can work together to decrease the opioids. And if we are, there are some recommendations within OPEN for how many opioids to give if there's a patient that you think requires it. So you can see a lot of them are zero, but there can be some. So tonsillectomy is one that we say, yes, some of those patients will. You can obviously read through the list, but we have more online about if there are patients who need it, what the maximum dose of opioids that we should be providing. As with everything, these aren't rigid rules. Protocols are in place to be guides as opposed to be strictly followed. And that's something that we all have to use, but it is nice to have something that gives you sort of a bellwether of where to start from. And with the patient, you're of course going to determine the best prescription size based on their individual risk factors. Are they at risk of having opioid dependence? Are there other strategies that they've tried and failed, or have they not even tried? And what is their pain management? And checking in regularly with them to determine if it's working or if it's something that needs to change. I can't give any lecture about pediatric dosing without reminding everyone that they're weight-based, and you certainly have to consider that, and to certainly consider obesity when prescribing opioids, to never go above the adult dosing, and to consider their ideal weight as opposed to their actual weight if the patient is obese. So we'll next go into sort of screening and identifying patients at risk of opioids. You want to make sure that you implement screening practices so that we are giving equitable care when we're doing that. And the strategies have been implemented at Michigan Medicine since about 2019. So we screen for each individual patient opioid-related risk. This may be family or personal history of substance use disorder. It could be known dependence. It could be that they have a sleep apnea, might have increased risk of having respiratory depression. Whatever their risk is, you want to assess for them. And then we want to educate. We only use opioids for severe breakthrough pain. We would never recommend that would be the only medication for pain. All of the patients, unless they have a contraindication, should be receiving Tylenol and Motrin, and then using the opioids only for breakthrough. We also want to teach them how to taper the opioid use as the pain improves, let them know about the side effects. Obviously, the big ones with sedation, respiratory depression, or dependence, but also things like constipation. I used to see not an infrequent number of kids back in the emergency department after an appendectomy for severe abdominal pain, and it was many times constipation from the opioids. Luckily, that has decreased since I decreased my prescribing pattern. Of course, the family and the child have to know about the risks of opioids, including addiction, overdose, and misuse. They should know how to safely store and dispose of the opioids, because if they don't use all of them, we don't want them sitting in the medicine cabinets to be used by others. And then if we think someone's at risk but does need pain control, then we should certainly educate ourselves about how to prescribe and teach families how to use naloxone. And lastly, we want to coordinate. Sometimes these patients are really complex, and the surgeon and the primary care provider need to work together. And sometimes we need to even include a chronic pain specialist. And so those are the ones that we want to really lean into and try to help. We, of course, want to make sure our language is respectful, understanding that substance use disorder is a disease, and we want to mitigate any stigma that goes along with that. So we want to screen our patients and provide follow-up in a caring and loving way, as I'm sure all of you on the call do. So information for parents and families, again, this is sort of redoing it, but set clear expectations, discuss effective alternatives, explain the safer use, talk about risks, and advocate for disposal. This is just a quote from one of our research assistants who says, I think it's really important that people educate themselves about the risks. I hope people take that initiative and see that this work is important. So we certainly hope that for you guys today. And coming up on conclusions, but certainly some of the additional considerations that I found helpful. Your order sets, for a lot of us, obviously we use the electronic health medical record, they may be outdated. And so you want to look into those and be sure that it is easier to do the non-opioid pain medications than the opioid. Checking any medication monitoring programs before we prescribe opioids. Connect for us surgeons, connect with the primary care providers and vice versa. And we do have some resources on our pediatrics page, which I think again is going to be entered into the chat in case you want to learn anything more. And that's it for me.
Thank you so much. So I want to introduce myself. My name is Zara, and I am a program specialist with Open. And we wanted to take a little bit of time during this conversation to share some of the youth, other youth initiative and youth engagement work that Open engages with. So recently, Open has announced our new youth engagement initiative with the goal of educating youth about opioid use disorder and its associated risks. We have, in addition to a lot of resources on our website, two programs that engage youth in a lot of different ways, both ones that they can get involved in. So firstly, we are announcing that we have a new youth board program that we are started recruiting for this month. So while our team was working on developing some of these materials for pediatric patients and their families, we found that there was a gap in the inclusion of adolescent voices. This is a time that they are just starting to kind of figure out how they want to advocate for themselves. And we wanted to fill this gap by creating some resources where they feel empowered to talk about their own experiences in the pre and post-operative setting, but also with their experiences with substance use in general. So this board is in development right now with the goal of increasing that adolescent voice in pain management and opioid use, and with the intention of using the youth's experiences and their expertise on on the best ways to engage youth so that they are bringing their thoughts and using that to help our message reach the youth more effectively. So the group is planning to develop some educational materials that are tailored to their peers, as well as build partnerships with each other and with other organizations that serve youth in the area, and also ensure that their diverse perspectives and voices are included in these discussions. And part of the decision-making process is on an individual level, as well as kind of the overall discussions that we have around opioid misuse prevention and treatment. So our youth part of the board have been a huge impact on some of these resources that we have created already. The first one here is the Open Teen webpage. And so this was launched earlier this year, or I guess technically now late last year, with the goal of answering some of the questions that you shared with us. So when we talked to them, we asked, what are the things that you don't understand or would like more information about around the opioid overdose crisis? And what they let us know is that they have questions around it on how they can help themselves, how they can help others, but there isn't really a place online to find that. And it's not a conversation that people are comfortable having with each other. And so this webpage was put together. The questions were developed by the youth that we were working with directly. And the language was specifically targeted through that feedback from the youth of how do they want to learn about this? What are the ways that they are getting this information that resonates most deeply with them? So that is kind of the goals of this webpage and how Open Teen was put together. We also have another example, which is this action planning for healing after surgery resource on our website. And so this document is meant to be used by patients and their families in that preoperative period to provide them with those tools and that language on how to talk to their surgeon or their other kind of preoperative team to share their thoughts on how they imagine the surgery will go, what they how they kind of see recovery to look like. And so the goal for this is, again, to provide that resource that empowers the adolescents to take this into their own hands, be able to have that conversation on their own with the support of their medical care team and their caregivers. We also additionally have Painless, the opioid musical, as a research that was developed by our team at Open in collaboration with the University of Michigan School of Music, Theater, and Dance. And so this musical was produced in order to tell real life stories about opioid overdose and recovery. And this is a really unique offering that we have. The program kind of allows schools in the area to be able to receive a live performance of the musical, which is performed by students at U of M. So the idea is to have kind of peers that are in a similar age range telling these stories and helping the youth that are listening to them really find that connection. So the musical was developed to complement the traditional high school curriculum that exists around health for substance use disorder and opioid use. And so really to supplement the education that they already receive and kind of be able to apply that in this setting. And so when these performances take place, again, local high schools can receive that performance. We've also developed a toolkit that educators can use to help have those discussions with teens, as well as that lyric sheet and an album that that youth and anyone else is interested can listen to on Spotify or anywhere else that you get your music. So we have a lot of resources that providers and educators can use to help have these conversations in addition to getting to view the musical. So it's been really nice to hear the feedback that we get from the high school students that view the performance and how they talk about being able to connect to the stories, being able to get that deeper understanding, and really being able to see how the real life impacts of this issue and kind of what the next steps look like in order to get engaged and help make a difference in their communities. We wanted to end off by sharing a couple of the other resources that Open has, both around the topics of pediatric and youth engagement, but also around substance use disorder treatment and other types of pain management. We have a number of scientific publications, as well as education and training in addition to this one that you're attending today, more materials and resources around public health policy. And so you can find all of those on our website. And finally, we encourage everyone to subscribe to our email mailing list if you're interested in getting more information from Open about the resources and up-to-date news and policy updates as they come out.
So please notice this is the information for the continuing education credits. You can scan the QR code by using the camera option on your phone, or you can click the links below the QR code to access this information about obtaining your credits. This will also be emailed to all attendees, so you will also get that information there. And with that, I will open it up for any questions that anyone might have. I will leave this up while we're going over the Q&A so people can access that. And if anyone does want to unmute themselves and ask a question, they can raise their hand and we can unmute you.
So we've got one question. for you, Dr. Prud. Can you please share a little bit more about how to understand and interpret young people's communication of pain? So example is when you're talking about the best practices for caring for young children, and they're unable to verbalize their pain. How do you interpret that?
Yeah, that's a great question. For older kids, I mean, at least kids who have normal development, using the 0 to 10 sort of Likert scale, I think is fine. But you know, the younger kids or the kids who may have some developmental delay, we tend to use there's some smiley face versus sad face scale, and it's like how, you know, the again, kind of mirroring the 10-point scale, but you know, the very happy smiley face, and then the not very happy, the like crying with one tear, the crying like lots of tears, and then the losing their ever loving mind face. And hopefully the patient can then point to it to give us their actual understanding. And of course, if they can't, then we have to use the parent or the caregiver to be able to tell us what they anticipate their patient or their child is feeling. It can be challenging, which is why, you know, we try to use objective signs, but some of it is just the expectation. I also talk a lot about, I do bowel surgery for a lot of things, so as a general surgeon, but the pain of like the intestines waking up and that sort of visceral pain is different than incisional pain, and I do a lot of education about how that pain is not going to be aided with any external pain medication, especially any narcotics, and it could potentially only worsen that because it slows down the gut. So I think a lot of it is just doing our best to educate and have appropriate expectations beforehand. But it can be hard in those nonverbal young kids.
Thank you. Okay, we've got one other question. What are some practices or suggestions for how we can help caregivers to prepare themselves and to prepare young people for surgery? What can we do to support them in helping that preparation? And
Good. Yeah, that's a good question. I think we have a ton of resources online, checklists, things, you know, just things that people may not think of, you know, like the heating pads and the ice and the alternating and those things. And I sometimes feel like people just want resources, and even though they kind of know that, having that list in front of you is easier than when, you know, you're nervous about your own child having any sort of pain. None of us want our kids to have that. But the real thing, I think, is just expectation setting. I try to be very open and honest about, you know, if I'm offering her, you know, an umbilical hernia, let's say, I don't want the kid in zero pain. The child will have pain. We try to minimize it. We use a lot of local anesthesia. You know, we recommend the Tylenol and Motrin around the clock, and that, you know, just sort of expectation setting. When we always, of course, give them access to our team to, if they do have problems or questions in the middle of the night, I want them to be able to have somebody to call and talk through that. And sometimes patients need a little bit more. But I just try to make sure that their expectations are that there will be pain. Hopefully there won't, right? I always set expectations maybe worse than the reality so that hopefully it's a better experience than they even think, but then they feel pretty prepared for whatever it happens to be.
yeah, definitely. Here's another one. Can you talk about some of your experiences with non-medication pain management options? What are the ones that you've found have had the best impact on your patients?
Yeah. So I really lean, if they're inpatient, on my child life specialists. So I have to give all the kudos to them because they do all of that with, you know, play diversion and whatnot. And I will take zero credit for that, but I consult them early because they can help. But if they are going home, I do tell the families, I mean, by no means do I want a kid sitting around on a couch all day watching TV and having them, fed grapes. Sounds great, but it certainly is not going to help their improvement in their wound healing. But I do let them know that it's okay to be a little more lenient in, the screen time during that so that they can be distracted. But I also encourage them to, especially my kids who can, to take ownership into their healing. And I let them know that laying around all day isn't going to help them. That's actually going to make things worse. So I want them walking and getting up. I play a little game with all of my appendectomy patients that are in the hospital that they get to tell me how many times they're going to walk around the halls. They gave any number between 5 and 10. So they have to walk at least 5 times. But they, especially our perf dappies who are in the hospital a little bit longer, they, that's something they can have control over. And then, if they do more, then it's, fun in the morning and they get to tell me that they did that, and giving them something that they can concentrate on, I think is really the best thing. So get your child life people and if not, obviously the parents, and allow the patient, if possible, to have some control into their what they can do, so they feel that they have some ownership.
Definitely. So kind of building off that idea of ownership and autonomy for the young people, are there any other places that you see them or encourage them to take that ownership of their healing?
I mean, I think that we, all parts of it. I joke with all of the patients that we have restrictions after doing an operation. So I don't want somebody having a shower in 2 days. I don't want them underwater for a week. And I don't want them doing super strenuous activity for 2 weeks just to allow for healing. I do always joke that they can still clean their room and they can still help with the dishes. Maybe it's not the time to take the trash out because that's pretty heavy lifting. But I tend to put that, and I joke that, and I always say that in front of the patient and the parent, and I joke with every kid that they get a mom as well as a surgeon. So I try to let them know that like they still can lead their relatively normal life. They just have to be a little limited, but I don't want them to think that this is such a huge deal that, they can't clean their room, like, or make their bed. That they certainly still have that ability, and that I would expect them to still be able to do that.
I really appreciate that, helping them be really realistic about that.
Yeah.
Okay, I think we have one final question about how to support kids when they have an allergic reaction.
Yeah.
What are the best ways to kind of help in those situations?
Yeah, that's super important, and I'm glad somebody asked. I mean, luckily, there's not a ton of allergic reactions to our non-opioid pain medications. But certainly if there is, of course, the family has to let us know. I mean, like I said, they have a phone number to call us. The most common reaction will be a rash or something like that. They, of course, would have to stop taking the medication if we think it's related to that. And we'll have to give some alternate. But if it's an allergic reaction where there's breathing problems, we need to call 911 because I wouldn't want a kid in the backseat of a car on their way here that has no way to protect their airway. So like I said, luckily it's pretty rare with our non-opioid alternatives, but certainly that's something to look out for all the time.
Well, I think that's all the questions that we have right now. Thank you so much, Dr. Perron, for going through those.
Thank you. Thanks everybody for coming and spending your lunch hour with us.